Hey everyone, this is Dr. Mike Simber with OD Coder, and today we have an update on differentiating between when to use a 9.2 and 9.9 code and understanding the different requirements between the different levels within the 9.2 and 9.9 codes. Understanding the guidelines properly will help you bill ethically and appropriately. It will also help to reduce your medical billing errors. I read a study recently that said that up to 70% of medical billing contained at least one error on the first submission. In general, 9.2 codes can be submitted either to vision care insurances or medical insurances, while medical codes, 9.9 codes, are only submitted to medical insurances. The 9.2 codes are specific to eye care services. Two examples would be 92002, intermediate eye exam, new patient, or 92014, comprehensive eye exam, established patient. 9.2 codes are used by optometrists and ophthalmologists, primarily for eye exams, and some insurance plans may have specific guidelines. So in general, if a patient is coming in for an eye exam, in our practice we are using 9.2 codes. Medical codes or 9.9 codes cover a wide range of services. They're not just used by eye care providers. Two examples would be 99203, office visit new patient, or 99213, office visit established patient, and again used by various healthcare providers, generally accepted by most medical insurance plans. 9.2 codes can be either intermediate or comprehensive. To differentiate between those two, an intermediate exam requires at least 3 elements, whereas a comprehensive exam requires at least 9 elements. So you might think to yourself, 9 elements, that's a lot to get. But remember, if you do a slit lamp examination, you'll get at least 8 elements. So if you do a slit lamp examination, you have eyelids and adnexa, iris, conjunctiva, cornea, anterior chamber, lens, retina, and optic disc. So right there you have 8 out of 9 elements. You throw intraocular pressures and or visual acuities, you certainly meet that requirement. This is an important chart that we will be referring to quite often. This chart represents 9.9 codes and the criteria needed to meet the different levels, including level 2, 3, and 4. We're not including 1 or 5 for this talk today. Across the top, you can see the column headings: problems, data, and patient management, and what is required under each column. When we look at this chart, I like to compare it to a tic-tac-toe chart. And how do you win at tic-tac-toe? Well, one of the ways is if you have 3 across. So in the same way that if we achieve 3 across, if we meet this criteria and this criteria and this criteria, well, then we've achieved a level 3. So we just discussed one way of meeting that criteria is by having 3 across. And so 3 across here allows us to achieve a level 2. But that's not the only way to meet a certain level. There are 2 other ways to meet a certain level. A second way is to have 2 out of 3 in a column. So we've achieved this, and so we've also achieved a level 2. So again, we can have 3 across, or we can have 2 of 3 across, both ways of achieving a certain level. But there is one final way of achieving a certain level, and that is if we have 1 in each row. So for example, we have this criteria met in level 2, this criteria met in level 3, and this criteria met in level 4. And so that, in a way, we take the average, the middle, that allows us to achieve a level 3. Now that you better understand the tic-tac-toe analogy, let's look at the actual chart and dig in a little deeper. So for example, in this particular patient's case, they have 1 stable chronic. We've done 2 of these, and then they also meet low risk. So we've met a level 3 criteria, 3 across. And so that gives us a level 3. And in this example, we meet a level 4 criteria here, we meet a level 3 criteria here, and a level 4 criteria here. So which one do we bill? Well, what we've achieved is 2 out of 3, so we are able to bill a level 4. And in this final example, we've met a level 2 here, a level 4 here, and a level 3 here. So that is 1 in each level. So how do we code it? We code it as a level 3 because we have 1 in each. So let's dig in a little deeper to the requirements for these different levels. Let's start off with a level 2. So under a level 2, we have a self-limited minor. What does that mean? It usually resolves without significant complication, doesn't require extensive treatment. So 3 examples might be dry eye after prolonged computer use, conjunctival hemorrhage without trauma or systemic issues, or mild allergic conjunctivitis. Under data, it says minimal or none. So it bears repeating that you don't require, there's no requirement for data on a level 2. And then the third area is patient management, minimal risk. So the risk of complications is very low, minimal intervention. A couple examples might be warm compresses for MGD, recommending OTC drops for mild irritation, or avoiding allergens in the case of allergic conjunctivitis. So how do we meet a level 3? Well, under level 2, we discussed self-limited minor, but now if we have 2 of those, we can meet a level 3 criteria. One stable chronic condition, one that's long-standing and steady, and an uncomplicated acute requires more thorough evaluation, but low risk of complications. So 2 examples might be mild glaucoma, that would be an example of stable chronic, glaucoma that's stable, and an uncomplicated acute might be dry eye with a new symptom of fluctuating vision. Under data, if we review external notes from maybe a primary care provider about their diabetic status, so that you can determine the risk for this patient having diabetic retinopathy. A review of tests and ordering tests is fairly self-explanatory, but an assessment requiring an independent historian. So the patient might be a child, might have a cognitive impairment, might have a language barrier. Those would all be really good reasons for needing an independent historian. But proper documentation is required. An example might be patient unable to provide history due to advanced dementia. And then finally, under patient management within the level 3, low risk. So low risk of morbidity, complications, mortality, interventions, all low risk. 2 examples might be mild glaucoma with SLT keeping things in check. Another example might be dry eye with a new symptom of fluctuating vision. Adjust OTC drops as necessary. And moving on to level 4, this is the most complex. So we've talked about previously worsening chronic, stable chronic, but now let's move into some new areas. One would be one undiagnosed with uncertain prognosis, and examples of this might be a vitreous hemorrhage or acute corneal hydrops. You're not exactly how complicated this is going to be. Another area to dig into is one acute with systemic complications. So for example, having a uveitis patient with lower back pain or changes in refractive error combined with systemic symptoms of increased urination. And an example of one acute complicated might be a bacterial keratitis with uveitis or an acute PVD with a symptomatic retinal tear. And then moving into the data section, we've gone through all of these until we get to the bottom. And so this discussion of management or text interpretation with another external provider. So for example, we might document the name of the external provider, and here would be an example of proper documentation. So contact Dr. Smith, retinal specialist, to review findings of superior retinal tear, agreed on urgent referral for laser treatment, dating and including the time of the communication is helpful to allow us to meet the data section within level 4. But how about the patient management section now? Moderate risk. So level 4 involves moderate risk of morbidity, complications, mortality, and the interventions are all moderate risk as well. So a couple examples might be initiating or adjusting glaucoma medications with systemic side effects, managing uveitis with corticosteroids, and treating a progressive corneal ulcer with fortified antibiotics. Prescription management means prescribing new medications, modifying existing medications, continuing medications with active management, or discontinuing a medication. That would all fall under the prescription drug management. So let's look at this next section. Decision regarding minor surgery with risk factors or elective surgery without risk factors. So minor surgery, low-risk procedures often performed in office, little to no recovery time, and you can see the examples within optometry. Now risk factors increase the complexity of the procedure. So two examples might be a patient on anticoagulants requiring chalazion drainage, or a diabetic patient that has an infected eyelid lesion that needs excised. Elective surgery is planned, non-urgent, minor or major, but not medically necessary emergencies, that day. So a couple of examples might be referring the patient for cataract surgery and having that discussion about whether or not to proceed with the referral. Or the same thing could be true with SLT, YAG, CAP, or PI, whether you're referring those out or performing them yourself. And the last section under level 4 is the diagnosis treatment significantly limited by social determinants of health. And these really are non-medical factors that influence a patient's health outcome. And this can include economic instability, education, access to healthcare, social environment, or cultural or language barriers. So a really common example that we see in our clinics might require documentation like this. Patient unable to afford prescribed glaucoma medication, generic alternative prescribed with follow-up to monitor efficacy. Now that we've done a deep dive in levels 2 through 4 and the requirements, let's go through some case examples. So in case 1, we have a 25-year-old that was out bar hopping with friends the previous night, and she woke up with this red eye that she's concerned about. Her blood pressure and fundus evaluation are unremarkable, so we diagnose her with a subconjunctival hemorrhage. So what level should we code this at? So looking at our chart, we can see that we've met a level 2 as being a self-limited minor condition. We recorded minimal or no data, and there was a minimal risk under the patient management section. So in this case, we will code her as a level 2. And in case 2, we have a 77-year-old who reports stable vision, who has a history of cataract surgery and hypertensive retinopathy, along with hypertension and some other comorbidities. The vision is unaffected, and today the blood pressure is good, and the patient reports good blood pressure since the last visit. So our diagnosis is hypertensive retinopathy that is stable. So how are we going to code this patient? What level? So we meet the one stable chronic condition under level 3 and low risk in terms of patient management. So in this case, we're going to code a level 3. In this last case, we have a 48-year-old female who requests a second opinion on her glaucoma status. She's on maximum medications with Combigan BID, Azopt BID, and Zioptin QHS. Her intraocular pressures are in the teens. She has thin packs, adequate hysteresis. Her Tmax is in the mid-30s and low 40s. And we reviewed the visual fields and OCTs from her prior doctor, and we found some progression compared to the results that we ran that day. So our diagnosis is mild primary open-angle glaucoma. We're going to send her for an SLT by a different provider. We are going to discontinue the drops 1 week prior. We're going to resume Combigan the day after SLT. So how should we code this particular patient? Well, she has one worsening chronic in primary open-angle glaucoma, so we meet a level 4 in this column. Because we did an independent interpretation of tests performed by another provider, we also meet a level 4, and this represents moderate risk because of her Tmax, and we did prescription drug management, and because we are sending her, we had the conversation about SLT, and we're sending her for such, we made a decision regarding elective surgery without risk factors. So in summary, we looked at the 9-2 codes and talked about the difference between an intermediate requiring 3 elements and a comprehensive requiring 9 elements. We did a deep dive in the 9-9 codes, and I hope you better understand the differences between level 2, 3, and 4. I've been involved in a lot of chart audits, auditing other charts, and while occasionally I will find examples of overcoding, which is never appropriate, more commonly I find examples of undercoding. So now that you understand the differences, code to the level that is most appropriate. Finally, if you found this video helpful, like it on YouTube and feel free to follow along my YouTube page, and I look forward to providing more content for you.